Hello, I'd like to welcome everyone to today's Systems for Action Research in Progress webinar. Our theme focuses on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. And the title of our presentation is Classifying Multi-Sectoral, Multi-Organizational Health Communication Networks. I'd like to go ahead and present the agenda for today's webinar. My name is Shauna Moore, and I'm the Director of Dissemination and Research Development for the Robert Wood Johnson Systems for Action National Program Office. We will start with the introductions, then have our presentation and commentary, and end with discussions and questions. I'd like to go ahead and introduce today's presenters, Dr. Anna Hoover and Dominique Zephyr. Dr. Anna Hoover is a co-director of the Systems for Action National Program Office, where she helps organize cross-cutting and multi-network research studies designed to evaluate and compare public health strategies implemented across diverse settings. Dr. Hoover, a communications scientist and assistant professor in the University of Kentucky College of Public Health Department of Preventive Medicine and Environmental Health, conducts research in dissemination and implementation science, environmental health literacy, participatory risk communication, and stakeholder engagement in support of evidence-based decision-making. She also serves as co-lead of research translation for the University of Kentucky Superfund Research Center, supporting the use of research outcomes at the community, provider, and policy levels. Dominique Zephyr provides statistical expertise to the Systems for Action National Program Office in the areas of survey sampling, analysis of complex sample survey data, multi-level modeling, structural equation modeling, and analysis of experimental and non-experimental data. He completed his graduate studies at Vanderbilt University, where he obtained a master's degree in economics and a master's degree in Latin American studies. Our commentator for today's webinar is Danielle Varda. Danielle leads the Visible Network Labs team and spends much of her time building partnerships, managing the team resources and opportunities, and staying on top of customer needs and current system needs. In collaboration with her team, she leads the strategic direction and vision for the future of the company. She is the lead fundraiser, a regular keynote speaker, and the mother of 3 spirited girls. And now I'd like to turn the mic over to Anna.
Thanks so much, Shauna. It is a pleasure to be here today, and I must say a little bit odd to be on the other end of the microphone. Often those of you who attend regularly know that I sometimes moderate these in my role as the co-director of the Systems for Action National Coordinating Center. I would like to just remind folks a little bit about the Systems for Action program because it brings bearing on the research I'm about to describe here today. The Systems for Action program is really about addressing issues of fragmentation across the systems and sectors that have ways of contributing to a culture of health. So this particular work is looking at different kinds of fragmentation related specifically to information and communication. And it's very exciting work that we're doing intramurally at the National Coordinating Center, and it connects also to some extramural research that is being funded through the Robert Wood Johnson Foundation through the Systems for Action program. And our commentator today is actually one of the grantees from that program whose work aligns with this in many important ways. So I'm really excited to be able to share some of this intramural work. And again, this is work that I've been working on with Dominique Zephyr and our entire intramural research team here at UK. And I think that what's important about this story is a microcosm of the research we're doing. I want to talk to you a little bit about why it's important to have so many perspectives at the table, whether you're talking about organizationally in terms of putting communication out into the world, or whether you're talking about a team of people who are working together to provide complementary expertise and fill in different gaps. So it's really exciting to be able to share this work. A quick agenda for what we're going to discuss over the next half hour or so before Danielle has an opportunity to respond. We're going to start with a little bit of background, and that requires a little bit of background about my own work and how we got to the research questions we're asking and how we put the team together to address these issues. We'll talk a little bit about methodology. I want to share some emerging findings, and rather than having a traditional findings, discussion, implication section, I want to talk about what we're learning from those findings and what questions they're raising as we're going. And then we'll talk a little bit about what some of the next steps are, and then turn things over to respondents and to you with your questions. And I do recommend that if you have questions over the course of the webinar, please do type those in the chat box. Type them as you think of them so that they don't get lost in the offing. So thank you so much, Shauna. I want to begin by talking just a little bit about research translation, dissemination, and implementation. I think most of us who work in health, healthcare, public health, academia know that we have this tremendous gap in research translation, the amount of time it takes us to get from findings that can really help move the needle on health and well-being in this country, and their implementation in communities, at the bedside, in hospitals, wherever that may be, whether it's patient level or community level. We're looking at 14 to 20-year gaps in the time from a research finding to its making its way into common practice. Part of that is because in the past we have relied on diffusion of innovation. So what happens is a researcher finds something that's important, and the researcher then publishes that in a peer-reviewed journal that sits behind a paywall, and it takes a very long time for people in the real world to hear about that. Thankfully, over the last couple of decades, we've been moving increasingly to models of dissemination and implementation research. And dissemination is really the targeted sharing of that information, making sure the information is tailored for the right audiences, making sure that we are pushing it to the right folks, making sure we're doing implementation studies to ensure that programs that are evidence-based are reaching the number of people they should and are experiencing fidelity in ways they need to, but are able to adapt in ways that they can. So we have this whole field that is really building up about understanding how we can shrink this gap from research to practice to population health and well-being. So my research connects very closely with that kind of work. And specifically, I have a background in health and risk communication with a dissemination and implementation science focus. Most of you know what health communication is, but I'm hoping that we have some folks from other sectors on the line. So I just want to share a sort of common definition of health communication, which is about the study and use of methods to inform and influence individual and community decisions that enhance health. So this is not just about your doctor communicating to you about the most recent test results and what that means for your health. It's about how the community makes decisions about health as well. And my particular milieu within that health communication world is around organizational sense-making capacity. So I'm interested in how organizations share information in ways that inform decisions, how they make decisions. And there's an entire body of research that was started by a man named Carl White about 30 years ago, and it builds on prior work in sociology and management studies that is about how we understand the information we are given. And one of the ways we understand the information we are given is through the capacity to interpret that information. And capacity is dictated by the number of people involved. So the idea is this is all relational. How we understand the world is relational and has to do with how we talk to other people and what we learn from our experiences and their experiences. So when we have more people at the table, or in this case, when we have more organizations at the table with different perspectives, we can see a broader range of solutions to challenges. We can identify different kinds of challenges. I look at the world from a very public health communication perspective, which may not hold the answers to what's driving a particular phenomenon or what is challenging the implementation of a specific program. Rather, what I need at the table is someone perhaps from a social services organization to say, well, what you're not understanding is in the real world, this is what happens with my clients. So having those folks at the table is really critical for understanding the challenges to these fragmentation issues that Systems for Action addresses, as well as coming up with solutions to address those challenges. So we're able to recognize more opportunities. And in the context of health communication and how we share evidence-based information, we're able to recognize more opportunities, more challenges, more audiences, more messages that we might be able to share. In addition, having more capacity or having more organizations and sectors and systems at the table helps us expand our reach. So that information can reach different audiences. Some of the connections to social services organizations, they may be connected to different people than a College of Public Health, which may be connected to different people than private industry. So if we work together, we can amplify messages. We can complement each other's messages and reinforce messages. We can build more efficient and effective ways of sharing information to ensure that communities move toward greater health and well-being. We also run into challenges from time to time with varying levels of organizational credibility with stakeholders. For example, I work in a lot of Superfund communities, Superfund National Priorities List communities, where individuals have been receiving information for a very long time from a wide number of organizations. So they may receive information from the National Institutes of Health, from CDC, but they may also be receiving information from the Department of Energy or the State Department of Environmental Protection or EPA, and those messages don't always coincide. Sometimes they compete a little bit. Everyone's not always on the same page, which over time can deteriorate trust in some of these agencies. So we have varying levels of organizational credibility with stakeholders. So someone may trust their doctor's office far more than they trust the university, or they may trust their employer far more than they trust the local health department. So you have to have a number of these different kinds of organizations at the table so that folks can really connect to someone they trust, an organization that they trust and that will benefit them. So having a number of different organizations across sectors and systems within a community who are contributing to health messaging is really critical for ensuring uptake of the lessons from that messaging. So in reality, when we try to think about how this happens in reality, we know that all of these sectors can play critical roles in communicating evidence-based health information, as well as in helping us implement evidence-based programs. But what we often do is we expect those research findings to go directly to improve population health, and we forget all of the steps that happen along the way. So the first thing that happens is we have research findings, and we need to share that information with people who can put it into use in the real world. Now, what we often do, and this slide was animated, so I apologize, because I was going to tell this cute story with just the right boxes popping up at the right time, so please bear with me. What we usually do in the research community is we partner perhaps with practice-based research networks, perhaps with hospitals, other kinds of organizations. But we usually, in population health, health services research, all of those kinds of research, when we have findings, we usually partner with healthcare, local public health, and state public health. And then we expect that to improve population health. But what we're missing is exactly what I was talking about a moment ago in terms of who each of those sectors, who each of those systems is touching. Often healthcare, local public health, and state public health have some overlapping audiences. And the folks in a disparities climate, in a climate where we are constantly working toward health equity, who are not connected to those systems, who are already probably experiencing poorer health outcomes because they're not connected to those systems, and who therefore need the information, need the programs perhaps more than the folks who are already connected to these sectors, don't get exposed to the message. They don't get the information they need. So what we need to be doing is figuring out how to capitalize on these other organizations, non-governmental organizations, community organizations, faith-based organizations, private industry, employers, educators, housing and urban development, other kinds of agencies that connect to different audiences, different stakeholders, different populations who are in need of information and programming about health. So this fragmentation of information flows, where information is not necessarily moving across these organizations, let alone through them to the populations of interest, can really inhibit our ability to disseminate and implement evidence-informed strategies. So we need to start understanding how we can get these folks together to amplify the key messages and programs. What we need to do that is understand what the lay of the land is right now. What does health communication from an organizational standpoint look like in communities? So we got together as a research team and we said, this is what we need to know. Who, what organizations, what sectors are contributing to health messaging in a community, are sharing information about evidence-based health and well-being in communities? What organizations are involved in that? And how is it varying across community types? Does it vary with rural areas and urban areas? What kinds of activities are they engaged in? What audiences are they trying to reach these different kinds of networks? And what are the optimal configurations or constellations of organizations in communities sharing health messages to really help see some real outcomes in terms of health and well-being. Well, we have a data source that many of you on this phone have heard of many times in the past, the National Longitudinal Survey of Public Health Systems, or NALSYS, or NLSPHS, depending on when you're using the survey. I think that the older version, most of you may recognize it as NLSPHS, but it's NALSYS, or the National Longitudinal Survey of Public Health Systems. And that is a database, a set of data that goes back to 1998. It was developed and implemented by our director, Glenn Mays, at the National Coordinating Center for Systems for Action. And it has been issued in waves. You can see here the years that it's been issued over the last 20 years. So we have a cohort of 360 communities in 1998. When this was first issued, the survey was fielded to 360 communities with at least 100,000 residents. Now, who was it fielded with? Well, it was fielded with the local public health agencies because you can't survey everyone at all times. Resources clearly won't allow that. So when we're interested in what kinds of health-related activities and services are being delivered in a community, what we really want to do is talk to someone who should have their finger on the pulse of what's going on in that community. And that organization is usually the local public health agency. They usually have a better sense of what's going on overall within the community than other organizations. So we reach out to local public health officials and give them this survey where they assess a wide number of activities in their community. And what we're looking for is the scope of activities. So are they available? What activities are available in your community? We're looking for network density. So what organizations within your community are contributing to this activity? We're thinking about network centrality. Who is the strongest central actor? Now, obviously, when you're asking the local public health agency who's the strongest actor on health in their community, very often you're going to hear that the local public health agency is the strongest actor. That just makes sense. So that's something that you have to think about when you're analyzing data and interpreting them. And then we want to think about the quality, perceived effectiveness of the activity. How well does the local public health agency think that the community is managing this particular activity or this particular service? Now, it's important to recognize that that is a very, very subjective measure. How well do you, sitting in your one organization, think that your community is doing this activity? So we often don't use it in our analysis, but for this particular analysis where we're thinking about communication activities, it really is important. It is an important barometer of what public health officials think about health communication in the community. And the reason it's important is because if they think they're doing it well, they may not be willing to change much. If they think they're doing it poorly, they may think, well, we're not going to do great at this. This is not our mission anyway. In some ways, it's just a minor part of what we do, so we can't focus our resources on that. So there are a variety of reactions that could happen if the local health agency thinks that the community is doing particularly well or particularly badly in terms of health communication. It also could affect the kinds of partnerships they're building with other organizations to help generate and amplify those messages. So we are interested in perceived effectiveness of activity in this case. What you see on your screen right now is just a screenshot of one of the questions about communication from the National Longitudinal Survey of Public Health Systems. And this particular question focuses on lay publics. So it's asking, in the past 3 years in your jurisdiction, has the public regularly received information about current health status, healthcare needs, health behaviors, and healthcare policy issues? So it's a binary answer, right? Yes or no. We're either doing it in our community or we're not. Lay publics are getting information. We have this same question really in 3 forms in the longitudinal survey. This one asking about lay publics. We have another question that asks about policy audiences. Are policy audiences regularly receiving this information? And we have another question about mass media. So these are 3 different audiences of interest. And we wanted to think about, what do these networks look like, and how are they handling communicating with these different audiences? Because these are the data that we have right now. And now we're going to talk in a few minutes about where we're going to go with this in terms of accruing additional data and looking at other kinds of outcomes. But for a starting point, this is what we wanted to do. So getting back to my original point about teamwork is important. I'm a primarily qualitative researcher. I do a lot of participatory research in communities, as I mentioned earlier, with environmental health at-risk communities. I don't do a lot of statistical analysis. I can do some, but it's not my forte. But we have a research team with different expertise. And Dominique Zephyr, my co-author, who is on the line here, is a tremendous statistician. He is a tremendous analyst in many ways and develops a lot of models. We have a great team with a couple of folks on it who build these kinds of statistical models. We have a terrific group of people with different expertise, people from public health backgrounds, people from health economics backgrounds, people from, as I said, statistics, public policy, business, all of those different kinds of backgrounds. When we sit around a table, everybody has a different piece of the puzzle, and we're able to put that puzzle together and say, okay, here are the questions. How do we answer them? So what we came up with for this was to look at the health communication networks and start classifying them based on their density. So what is the proportion of organizations that contribute to activities in a community? What is the proportion of organization involved in some kind of regular communication activity in the community? And how does that shake out? Do we have 4 or 5 or 6 different network types? Do we have 2 or 3 that predominate? So we started there. Then we wanted to look at how the different kinds of organizational health communication networks were associated with the probability of their engaging in these kinds of activities, engaging in communication with each of these audiences. And we had to control for some variables because communities are very heterogeneous. So any of these pieces could potentially affect our analyses. So we needed to think about the existence of a board of health or the unemployment and poverty rates, what percent of the population in the community is uninsured, what position is non-white, what percent has a college education, what percent is over 65 years old. We had to control for all of these so that we were trying to get a real picture of what do these networks look like. I'm going to share some emerging findings with you right now. The first thing we found was that there were really 3 network types that hung together when we ran the analyses. And those networks were minimal, which was a very small density, meaning a very small number of organizations in the community participated in communication activities in that community. And usually the organizations that were communicating within these communities were hospitals, state health agencies, other local agencies, and local public health. So really you're talking about governmental communications and hospitals, which is your public health and healthcare sectors, which are the 2 that we most frequently connect with, as I mentioned earlier, as researchers to disseminate information. So those are sort of hitting the traditional audiences that we always expect we're going to hit when we're trying to do dissemination and implementation research. Then we found expanded networks, which were sort of our in-between group. They were the least common of all of the classes that we found of these networks. They made up about 27% or so of all of the networks that we saw. And what we saw in the expanded networks was an increased number and diversity of organizational communicators. So other organizations are starting to come to the table and help push out health-related information. In that group, we saw more, we saw the same sectors that we saw in the first, so the health and public health, governmental public health sectors. We also started seeing faith-based organizations, nonprofits, community health centers, schools started getting involved, and physician organizations were getting involved. And then we found the most common of all the networks at 38% were robust networks. And these were much higher density networks where all of those earlier actors I mentioned were at the table. And they started bringing in universities and others. So we start getting a more complete multi-pronged press, so to speak, a full court press on the organizational health communications front in these robust networks. Not surprisingly, these robust networks were more common in urban areas than any of the others, and we'll talk more about that in a minute. We also were curious what kinds of organizations are most involved in sharing health-related information in communities. And as you won't be surprised at all from that last slide, hospitals were, in addition to local public health, who are of course answering the survey, hospitals were the most common organizations perceived by the local public health agency as sharing health information in these communities, along with local government and nonprofits. And then you start seeing it winnow down until you get to the very bottom, and you see that federal government is not really perceived as sharing health communication in local communities. Health insurers are not really seen as doing it that much. Now, this raises a key question that I think we have to explore moving forward, which is, are these organizations not sharing information at the local level, or are the local public health officers answering the survey perhaps not thinking of certain activities or not aware of all the activities that, for example, I don't know about you, but I get regular mail from my health insurer with wellness tips and all of that. So there are possibility that we have some qualitative work to do here. We definitely have some qualitative work to do here to explore the possibility that perhaps some of these organizations are contributing more to the health information environment than we're aware of. All right. Now, I did say it was a longitudinal survey. Those questions, those findings I just shared were based largely on the 2016 wave, so the most recent wave. But we would be remiss if we didn't start looking longitudinally at, okay, what are the trends since we have all of this data? So far we've only had a chance to go back 2 waves. So we've gone back to 2012, which was the last year before we added rural jurisdictions, to look at what is going on in terms of the landscape. What proportion of the network landscape are these different classes making up? And what we found was in 2012 when we first looked at it, robust was sort of at the top of the heap, and minimal was way down near the bottom. And then in 2014, something interesting happened. We saw a spike in minimal networks as a proportion of communication networks that we examined. And we saw a dip in robust. So they actually switched places. All of a sudden, the minimal networks were the most common, and the robust networks became sort of middle of the road, less common than the minimal networks. And then we've sort of seen a correction in the most recent wave, where we again have robust networks comprising more communication networks, with minimal sort of in the middle. Expanded has sort of been flat the entire time. They've occupied right around 27-28% of the landscape for each wave. What else do we find? Variation in rural and urban network types. And this is something that on the surface of it is sort of a common sense finding, something that you might expect to see, which is that rural networks tend to be more minimal. There tend to be fewer organizations involved in communicating health information in rural areas, and a lot more organizations involved in communicating in urban areas. There are many reasons that we can think of off the top of our heads for this, and I'm sure you're thinking as you sit there, but at the surface, the first and foremost one you might be thinking of is there are probably fewer organizational partners in rural areas to be pushing out health information than there are in urban areas. So if you're thinking of an urban area with 5 or 6 hospitals, the likelihood that at least 1 or 2 of those hospitals is seen as pushing out health-related information is pretty good. Whereas if you have 1 hospital in a rural area, or it's served by a hospital that's far away, then the likelihood that hospital is perceived as communicating health information might be a lot lower. So we've got to be thinking about how do we interpret these findings, and that's really going to involve us having to talk to some of the health officials who are filling out these surveys, as well as talking to some of the organizational partners in communities. So maybe we look at a community and say, this says there's no hospital communicating, and we call up the hospital folks and we have a conversation with them about, do you share health information, so we can sort of validate the perceptions of the respondents. So I think that that's going to be some important work that we're going to have forthcoming. We also have seen network variation in community activities by audience. So it is more likely in every case that robust networks engage in communication with these specific audiences. So robust networks are more likely to communicate with mass media, they're more likely to communicate with elected officials, and they're more likely to communicate with lay publics. In the case of minimal networks, they are the least likely to be engaging in all of these activities. I think we can, again, think of a lot of reasons this might be related to resource constraints. So related to available partners to be engaging in these activities. So I think that it aligns well with some of the other information we're seeing. And I think we're going to have some real conversations and engage in some interview activities, perhaps even some focus groups with these folks in these communities to be thinking about, okay, why are we seeing what we are seeing? And are you satisfied with what you're seeing here? We also, when we look at this, wanted to look at, again, going back to perceived effectiveness. We were very, very interested because of the potential effects on future communication activities of how well the public health officials think that their communities are receiving this kinds of information. How well are the organizations pushing it out there? And what we found was really interesting in exactly the direction you would expect it to be. Robust networks think they're doing a better job. Now, is that true? Unfortunately, this is a very sort of high-level data set. What we're finding with this data set is, are these activities engaged in? We're not really getting down into the weeds of what kinds of products are you producing, what kinds of information is being disseminated, to whom, through what channels. None of that information is contained in this particular data set, which is our starting point. What is contained is who's doing it and what are they doing, and how satisfied are they with how well it's being done. So again, we're looking here. We would expect that those more robust networks with more partners might think they're doing a better job. How does that play out in actuality? Well, we're going to be looking at that, and I'll explain that in a minute. So I want to mention some limitations, and I've sort of mentioned them as we've gone along, but just to be clear, we have self-report data from a single community organization, and it may not capture the breadth and depth of all of the organization's involvement in the community health communication activities. So we're capturing what one person knows about the health communication activities. One person who sits in a very important agency that should have a knowledge of all that's going on in the community related to health, but there are always some concerns about how well that captures the real context. We also know that these networks are constructed for participation in activities. These are not what you would normally think of as in network analysis as an ego network. We don't know if these networks are specifically connected to each other, how well or how strongly. We don't know the strength of ties. We don't know what the direction of those ties are. We don't know how information is moving across the networks, and we don't know if they're sharing the same information, if they're amplifying each other, if they're complementing each other, if they're competing with each other's messages. So again, this is an opportunity for us to engage in some qualitative research moving forward to dig into these questions and find out, in networks that are very robust, do you think, talking to the different organizations, how do you all feel that you're doing, and what kinds of information are you sharing? Looking not just at one organization within the community, but looking at a robust community, an expanded community, and a minimal community, and really starting to think through some of these issues. And then again, that perceived effectiveness measure is really about what that one person thinks. And again, we're interested in that because, A, it tells us something about what might or might not be directions of health communication activities in the future, at least for that organization. And it also sets us up to do some comparisons between do those perceived effectiveness numbers correlate with actual productivity related to communication activities. So our next steps, as you might imagine, first we want to expand our longitudinal analysis to incorporate some additional survey waves. As you saw, we had some interesting movement in that 2014 year in the composition. So we want to examine in some depth, if we go back further, if that keeps happening or if that's just an aberration. There are a lot of reasons you can think of that something like that might have happened. And I think there are probably some questions in the chat box about it, so we'll talk about that in depth in a few minutes. But is there anything related to ACA implementation, for example, or the addition of rural communities? Are there different kinds of things that could be driving that switch? We also want to examine the variation in actual policy and media outcomes to compare with that perceived effectiveness measure. And when I say actual policy outcomes, for example, we're beginning some work looking at local tobacco policies. And so we want to know, do any of these networks appear to be more effective in promoting tobacco policies in communities? Are more policies enacted in those communities? And that will help us figure out, if robust networks are in fact more effective at doing that, then perhaps their perceived effectiveness score is correct. But if If they're less effective, then we have some additional questions asked. That's the great thing about research. For every question you answer, you come up with 10 more. Then we are going to conduct some qualitative interviews to start exploring with the different organizations in a subset of each of these community types and begin really digging into these questions from a qualitative perspective. Finally, we want to do some member checks of some of the interpretations of the emerging data that we're coming up with. So if we think that rural communities tend to be minimal because there are fewer organizational actors, is that what the people who are in those rural communities really think? Is that why they think they're choosing minimal networks, or is it some other set of factors? We do have some dissemination activities coming up. We're very excited for the APHA annual meeting presentation. If you're in San Diego this year on the 13th of November, please join us for that session. And we also are finalizing a manuscript describing the descriptive findings here. So really just a manuscript that sets up the three types of organization, what we've learned so far. So with that, I know we have some questions in the chat box, but I also know that we have Danielle Varda on the line with, and she is exactly the kind of network researcher that I mentioned a minute ago when I was talking about needing to partner with collaborators who do network research and start looking at those ego networks. So I'm going to move to the side here and pass the mic back to Shauna or Danielle, whoever wants to take it next. Thanks.
Great. Thank you, Dr. Hoover, for reporting on this interesting subject. This is Shauna. I'd like to go ahead and see if Danielle, would you like to comment now on the project as a whole or jump into some of the questions and discussion there?
No, thank you. This is Danielle Varda. I have a couple of comments. I'll make them really quick so we can have time for the discussion and questions. And so I have two comments, and then I have a question that's really come up thanks to Anna's presentation that I think hopefully I can ask. I don't know if it can be answered right in the call, but so I wanted to kind of talk about a few things. One, that networks are so complex, and there's never going to be one way that we could know everything about this topic of networks. So the real beauty of this kind of work is that so many people are working on it in so many different ways. And I think that in the broad scheme of what we know about how people work together and how organizations work together and the impact of that on our health and well-being is enormous. And we are just at the very, very cusp of any real understanding. And one of the reasons for that is because it's really hard to get the data. And it's really hard to understand the data because truly what we're talking about are relationships. And so to present an idea that we are measuring relationships might not even resonate with a lot of people. We think of relationships as something maybe intuitive, more human nature, very difficult to measure. So it's really neat to be a part of a community of people who are working so hard on this. And I think things we have to think about are the different levels of analysis. So like, what are we measuring? Are we thinking about an individual actor in a network? Are we thinking about their dyadic relationship or their relationship among three or more entities? And that is how we look at networks, and defining who those actors are and who's a member of a network. I always say to everyone, is the absolute hardest part of doing primary data collection on networks is really defining actors and even labeling them and defining who's in and who's out. And then what kind of analysis we do is just varies. One thing I wanted to kind of bring up is a place that I got a lot of guidance for this was many years ago when I was at the RAND Corporation, and I went and audited a class at the University of Southern California with Peter Manji and Nashir Contractor, who was then at Northwestern University. And the class was on communication networks, and it really made me think about this. And they've written a book called Theories of Communication Networks, and in that book they talk about the MTML model, the multi-theoretical, multi-level model. And it's where I learned about these different levels of networks, how to measure them, how to think about networks as huge systems of all of these different ways of measuring, and really begin to understand the complexity of that measurement. The book is also full of theories of communication networks, most of the time that are competing with one another. So it's a fantastic model, and I'd actually, if you all are going to keep going down this path of communication networks, it's kind of an older book. I'm sure new things have come out, but it's a pretty guiding kind of piece of work in terms of empirical ways of thinking about this. So that was one comment. The second one, I wanted to talk a little bit about this issue of perspectives, or this thinking on perspective. So I heard Anna say that this was the public health perspective, and even that at one point you said the public health should have the most comprehensive perspective on this. And I just really want to challenge that in this way. I don't know if that's true or not, but that's the problem, is that I think that when we come from our own silos, we come from our own fields of research, we tend to believe that these actors that we know well probably have the best perspective. And I think that is one of our things we need to really challenge ourselves on, because it could very well be that this is the problem. Is the beauty of a network study where you are getting reciprocal information from people and organizations about their relationships, the more of a dyadic study or a whole network study, is that you get to understand perspectives. And I always say to everyone, there is no real measure of a relationship. I mean, we're all on a call together today, so I could say that we are on a call, but there's no real measure of a relationship. The real measure of a relationship is the perception that we have of each other. So the perception that you all on the phone have of me or Anna or any of us right now, and the perceptions that we have of you, is our real relationship. And so to capture that is important, and that's where we really start to dive deep into networks and understand when our assumptions about perceptions are kind of challenged. And so and along those lines, I actually wanted to bring up a couple of things. In our data set, we have what is the largest whole network data set on public health collaboratives that exists collected through surveys. It's through our partner tool and the partner data, and it's on these community-based networks where all the partners respond about each other. But we've found some really interesting things in that. And like, for example, one is that across networks we find themes that private sector organizations are highly valued for their on the value scores. But when you actually look at what people say they contribute to this work, private sector agencies hardly contribute anything, and our nonprofit sector is contributing 80% of most of the things that are happening. So the nonprofit sector is devalued in these networks while they're also bringing the most resources to them. So it's a really interesting way of thinking about how we think of perceptions around power and influence and value in these networks and what's really happening. And I know, Anna, you mentioned a similar kind of finding. So, and I have other examples. I'm not going to go through them about hospitals and public health and all those kinds of things that we have found. But I wanted to add one. When I was introduced as the CEO of Visible Network Labs, which is true. Some of you will know I'm still at the University of Colorado, Denver, but I've made a move into the private sector, kind of splitting those two realms right now. And I'm getting this unique perspective of being a private sector agency who is really interested in engaging in cross-sector collaboration. And for the first time, I am really starting to understand that while people in different sectors say they want to engage with people in other sectors, I think we also need to question ourselves to say, do we really mean it? Do we really mean that we want a bunch of private sector organizations coming into our public sector networks and engaging and making decisions and having governance and doing the things they do, given that there is a perception of private sector, as being money making and less mission driven? So, I'm gaining this perspective now and understanding that I myself have my own stereotypes about private sector agencies and my own, worry about their participation. And I think that if we continue to have those feelings, private sector, who is quite siloed, what they're doing in the health tech industry and for public health is enormously amazing and innovative and creative, and completely siloed from what the public sector is doing. So until we really embrace those stereotypes, I think, and really mean it when we say we want to engage across these diverse sectors, meaning outside of the public and nonprofit sectors, I think we're going to be stuck with not bridging that gap. So those are my two big comments. And then the last one, I actually just wanted to talk about data for 1 minute and then ask one question. The thing about these data is that no matter how much we have, it's almost never going to be complete, and it's never going to be the complete picture. This is really, really true for networks, and networks are dynamic and they change constantly. And so you collect data and the next day it's different. So many reasons that there's limitations about it. So I think it is important for us as researchers to be as clear as we can about those limitations, but more clear about what it is we actually have. And so this is a question I have actually for the research team, and then I'll end with it. From what I understand, and I've been trying to kind of understand the data that you all have, and it's a data point from a health department. I thought they were egocentric networks, but now I'm understanding, I think that you might be coding them as the activities that they're engaged in, which is actually an affiliation network, we call it, or it's an activity that a person or an organization is connected with. And there's a way to transform those data so that you basically you make ties between them if they have a shared activity. And I think that's what you all are doing. So it's a real by proxy kind of network. So I have two questions on that. I wonder, should the research team be calling these communication networks when I don't think you're actually measuring communication at all? I think you're measuring shared activities that they engage in. And so what you're showing is that if two people engage in the same activity, there's a connection. I could be wrong, so I'm kind of trying to piece that together. And I think that you all, if that's right, should be clear about that, because if we're saying this is how they communicate together, but it's really just an indicator that they're sharing activities with each other, I don't think there's anything wrong with that, but I think then we have to talk about it in a different way, like so that we're learning from it in the right way. And then number two, if that is the way that these are coded and structured, I am not sure how you're getting a density and centrality measure. I'm a little confused by those, so I'd love to learn a little bit more. How do you come up with a density measure if you're not connecting all the alters to each other, unless through the coding you're also giving them ties if they're sharing activities. But again, I think some clarity on that would be interesting. I think our use of the term network might be different, the way that I'm thinking of it and the way you're coding it. So, and nothing, not even, what I'd love is to better understand, because I think if we can think about ways we can combine these ways of thinking about this work, that's when we get a full picture of the strengths and weaknesses in these systems. So would love to think more with you all about that, but I wondered if you could give a little clarity on that before, just as my last question. And that's it.
Absolutely. Thanks so much, Danielle. Absolutely. And I agree with virtually all of what you said, just so you're aware right out of the gate. In terms of the public health having its finger on the pulse of what's going on in the community, I think that is the assumption of the data set. That is the assumption when this survey was begun in 1998. And I would like us to get more clarity on that, and that's why we're really looking to expand into qualitative research and expand into some different kinds of network research, the kinds of egocentric network research you're talking about, so that we can actually get the complete picture. Thinking about what your last couple of points I want to get to really quickly. The affiliation rather than egocentric network, for these communication questions, for these communication measures, it is absolutely affiliation. It is not an egocentric network. These are the organizations that are conducting this activity in this community. So I would agree that they are not egocentric networks, and that's why I think we need to be tapping your data sets and working with you on a lot of these issues to really try to figure out how does all of this fit together. Like I said at the beginning, when you bring people with different perspectives to the table, that's when we can really start fleshing out what are the challenges to this work, what are the opportunities, and how does it all fit together in a meaningful way to tell us a story about how we can improve health and well-being around the country. So I would say absolutely, I would agree with you completely that this is an affiliation network rather than an egocentric network for the communication measures, which are worded a little bit differently than some of the other measures in the survey. And I would invite folks, and we're probably not going to have time to get all of the questions, so I did see one question in the chat box about can folks access these data, and the answer is yes. There's a web page on the Systems for Action website. If you go there and you look for the National Longitudinal Survey of Public Health Systems, it will tell you what you need to know. It shares the instrument right there, so you can look at the instrument and start drilling down and thinking about what kind of data this is collecting, where might we have an egocentric network and where might we have an affiliated network. You can see how to get a data use agreement to use the data yourself and to conduct your own analyses. So I think that it's important for all of us to really dig down and think about what these data say and what they don't. And that's really something I've been struggling with, I'll be honest with you, Danielle, is how to characterize this, because it is in some ways an affiliated network of organizations engaged in an activity, but we don't have that important data on who is directly connected to whom and how strong are those ties and are they actually collaborating on this work. So I think that's where the next steps, those activities related to talking to the different organizations in the communities. And again, starting with Partner Tool might be a good place to look and see if there are data on any of these communities, where we can start looking at what they think that the different egos in the community think that the structure looks like, and see how that compares to what we have. Because I think that, as you say, perception is varied, and it is always individual based on your own experiences, and we have to try to piece things together. I think that's one of the greatest challenges of research, is to piece together enough parts of the story to know, to at least have a strong sense of what's going on and how to make it better. So I would agree with all of that. And I'd also encourage folks on the call to please check out the web page on the Systems for Action website. In addition to the National Longitudinal Survey, please check out the web page on Danielle and her team's current research on carrying capacity and how these networks, and particularly nonprofits, are carrying some of the additional load as referrals go up and up and up. So I think that that's really important work, very network science work that is far more in the weeds on a lot more of these issues than I am. And it's exciting to be hearing your thoughts on this work, and I'm hoping we'll be able to collaborate on this moving forward. So thank you so much, Danielle, for your thoughts.
Oh, thank you for letting me have any opportunity to talk with you and your team and the folks out.
Yes.
All right.
This is
so
Shauna.
I think
go ahead, Shauna. Yeah. Well, I wanted to thank you and Danielle for getting us started on discussion and start to dive into the questions before we run out of time. If that's okay, the first one came in from Michael. He's wondering, I think in your breakdown, potentially on slide 14, I'm going to go ahead and click to it, where state Medicaid agencies would get classified.
Hi, Michael. Thanks for the question. And I've got to be completely honest. I am sitting in a hotel room in Durham, so I don't have the instrument in front of me. So I'm not sure if it is explicitly coded in one place or another, or if it is the perception of the local public health agent completing the survey, which again gets back to some of the issues that Danielle was raising about the challenges of survey research and having just one alter at the table in each of these cases. So it could be that if it is not explicitly denoted in the instructions, and I can't remember that it is, but I hope Dominique or Shauna will jump in if I'm misspeaking, then it would probably be at the purview of the person answering the question. So I could imagine it might end up in, strangely enough, perhaps state public health or maybe even federal. It's hard to say where those state public health agencies would, or the state Medicaid offices would be coded. But if anyone else on the team is on the line and has the survey handy and can correct me if there is an explicit instruction, I would appreciate it.
Yes, I can get that answer from Michael after the call with the data administrator.
Great.
So
Thank
Michael,
you,
if you're
Shauna.
on the line, if you send in your email, we will respond to you with where those are located. The next question comes in from Jessica. I'm going to go ahead and flash to slide 15. She is referring to potential theories that may surround minimal networks jumping in 2014 and robust networks dipping. Do you have any theories around that?
Well, we're really developing some hypotheses around that, but I think to have a sense of how strong those hypotheses are and whether they're even worth exploring, we're going to need to go back a couple of more waves and see if that is an aberration. When you're only looking at 3 data points, it could very well just be some noise, something strange happening. It could be, as we all know, ACA was implemented in 2012, so did that affect who was issuing? It could have affected a couple of different things. It could have affected, who was actually issuing health information into communities, who was sending out health information into communities, or it could affect how aware public health agencies who were busy doing their own thing at those points were of what was going on in the community. As Danielle so rightfully pointed out a couple of moments ago, we often think of the public health agency as having more information about what's going on in the community, but if they're sort of very focused on solving a particular problem, they could be missing some other aspects of what's going on in the community. So there are a lot of potential drivers of that, but before I really committed to anything enough to say this is my hypothesis and I want us to really dig in and explore it, I want to know if that, looking at the longer term, is something that is really an aberration or if it's something that happens every few waves.
Okay. We do have another question in here. Did you have some precedents for the cut points that you created in the network density?
Well, I'm gonna let Dominique address that after I say this. The question I gave Dominique was, how are these constellations of actors, of organizational actors, how are they hanging together? Do we get 3 or 4 or 5 different coherent groups that we're seeing occur over and over and over again? And Dominique, if you're on the line, if you could talk a little bit about the steps you took in constructing those networks. We might have lost Dominique. Dominique, are you available? Are you on mute? Okay, I think we've lost Dominique. Yeah, it sounds like we've lost it. So what I'll say, Michael, and then we'll get back to you with a fuller response a little bit later, is that, again, the question was, when we look at the different clusters, are we seeing patterns? I'm always interested, as a qualitative research, I'm always interested in patterns. What do we see recurring over and over and over again? And Dominique came to me a couple days later and said, look at this. We've got very clear groups that are hanging together. We've got these 3 very distinct groups that are hanging together, and we looked at it, and it was exciting to see that we actually were able to discern some patterns in that, and we'll have Dominique share more. And the next time we present on additional findings as we move down this road and see what particular constellations of organizational communicators in a community seem to be driving policy outcomes, we'll also make sure that we have a slide about that in that presentation. Thanks for the question, Michael.
Okay. We only have one question to go, and it's from Jenny. Thinking about rural and urban, have you considered looking at the saturation of networks? What's available versus what's being used to take into consideration that rural areas may have less partners available?
I think that is an excellent question, and I think that's absolutely a road we're going to have to go down to be able to say anything sensible about this. We really need to know, it could be that in these minimal rural networks, every available agency, every available organization, public and private, is somehow pushing out information, but there are just fewer of them, and that in these very robust networks there are just so many that it doesn't take a whole lot, a large number to be really considered robust, because you have all of these sectors represented. So I think that saturation question is key. I think that's something we're going to have to be teasing out in future network work along the egocentric network work, as well as future work, qualitative work, to try to ask the people in the communities, what do you see going on? Where do you see partners that might be missing? And really to explore some of those issues that Danielle raised so well around, do you really want everyone at the table? So I think that those are key issues that we're going to be looking at as we move this work forward, and we're really excited about it and glad to share it. This is really early exploratory work that we've been engaged in to try to get a better sense of really how evidence-based health communication is happening in communities. Who are people getting their information from in their communities? And it's really exciting to be at the start of this project with you all, and I look forward to learning from you all. Please don't hesitate to contact us if you have questions or comments after the webinar. We're always eager to hear additional thoughts and get more perspectives at that table. Thank you.
All right. Thank you so much, Anna, for this presentation, and to Danielle. It looks like we're up to the top of the hour, so I'm going to go ahead and round out. We'd like to go ahead and direct you to our website for complete access to the slides from this presentation, as well as access to our webinar archives under the News and Events section. We hope that you will be able to join us for our next webinar, September 19th at noon, where we will hear about rural-urban differences in delivery systems for population health activities, presented by Systems for Action intramural researcher John Poe. We encourage you to register at systemsforaction.org. And just a brief acknowledgement that support for this webinar and Systems for Action National Program Office is by the Robert Wood Johnson Foundation. Systems for Action is the National Program Office of the Robert Wood Johnson Foundation and a collaborative effort of the Center for Public Health Systems and Services Research in the College of Public Health and the Center for Poverty Research in the Gatton College of Business and Economics, administered by the University of Kentucky. We want to thank everyone for attending this webinar. Thank you to our presenters. Thank you to the individuals that asked questions, and we look forward to seeing you online in the future. Thank you very much.